Hello, my name's Rebecca. Today we are going to be going through a fair amount of lines and ANTT, and I'm going to show you 3 examples as well. So let's go straight into it. IV therapy is very common. We are using it for a lot of our patients, but like everything, it comes with risk as well, including infection. So we want to make sure that we are having standardised practice. So making sure that if I was to do an IV right here, right now, and another colleague from this trust were to do a IV there, then we would be doing it exactly the same way, by the book, each and every single time. It makes it safe, it's efficient, and it reduces patients' harm. We also have the risk of needle stick injury to you guys, so we want to make sure that we are reducing that risk as much as possible as well. So we have all of our lines are needle free, so we should minimise the use of our needles. Then we go on to the microorganisms. I can stand here and talk you through all of them, but it's not about that today. It's about minimising the risk of infection. Okay. Principles of ANTT. Number 1, first principle of ANTT is hand hygiene. We are constantly touching a million different things all of the time. Door handles, when we come into a room, into your room of your patient, we are touching the patient. Therefore, we need to remember the 5 moments of hand hygiene, again, to minimise the risk of infection. Second, we have gloves and aprons. We need to be making sure we are using gloves and aprons correctly. So gloves and aprons are for one task and one task only, so not multiple tasks or multiple patients. So it is just for one patient, one task. Then we move on to protecting key parts, and a fabulous example of protecting your key parts is IV therapy. So when we are doing IV therapy, it's all about your key parts. So this includes the end of your flushes, the end of your syringes, your needle, why you would want to touch a needle anyway, but you never want to touch it. It's non-touch technique, and also the top of your vials as well. And then that leads me perfectly onto principle number 4, which is non-touch. Best way not to transfer any microorganisms is simply by not touching them. Key parts. So another example of a key part is the end of your IV lines. So I want to make this message really clear that only an IV trained nurse is able to disconnect an IV given set. 3 reasons. 1, that medication may be up for a particular reason, for a particular time, therefore we should not delay that medication. Second, you always have that risk of contamination when disconnecting a line. Third one is that even if the medication has finished, the line will still need to be flushed. So if an NA or a porter or a physio, I don't know, anyone who's not IV trained, disconnects the line and throws away that medication, the nurse who is looking after that patient may not realise that that line is not being flushed. And I will go through the importance of flushing a line later on. Here we go. Here's a random IV in which I just walked onto a ward and I saw this. A couple of reasons why this is wrong. Number 1, who's the medication for? No idea. There's a drug chart underneath, but is it for that patient? I presume so. It's already signed for, so I could be quite nasty. I could contaminate this medication, already been signed for. And then also you've got needles just there. So potentially I could have knocked it over, contaminated the needle. It's not worth it. Do not leave your medication unattended. You don't know who's out there, you don't know what's going to happen to it. So guard your medication, especially if you've already signed for it. And making sure that if you are doing medication, you have done all of the different steps, you have made sure that you have done all of the right R's, so that it is going to be safely provided for your patient. Once you put IVs into your patient, it's really difficult, if not impossible, to get it out of your patient. So you only get one chance of getting it right. Like I said, our lines are needle free, so why take a needle to your patients? And I will show you an example of why we do not need to bring the needle to your patient. Absolutely no point. Care of IV access, so before you do anything with your IVs, making sure that it is cared for properly, that there's no signs of infection and possibly no signs of swelling as well. You may not see it, but it may be there. Signs of uveitis, so uveitis can happen very quickly. So looking out for the signs of uveitis, so any redness, swelling, pain, and then knowing the difference between uveitis, infection, and then possibly the patient may be allergic to your dressing. So you have the difference by seeing the outline of the dressing all the way around it. So infection is localised to the insertion site, whereas the dressing is all the way around here. Okay, so just be aware that there is a slight difference. This is our care plan for our cannulas. So obviously we have the vein assessment. Sometimes you look at a patient and go, no, I will not be able to get a cannula in there. It will be very, very difficult. So fill out your vein assessment, and potentially if you can't do a cannula, you may need another IV device. Then we've got VIP scores, so we never should get to a 3 or 4, ever. All right, if we are doing VIP scores once a day, once a shift, we should never get to a 3 or a 4, because we will always be observing cannula and looking out for pain, redness, and then potentially swelling at a 2. And when we get to a 2, we should re-site the cannula. Once the cannula has been removed, the area could still deteriorate, so we still need to be making sure we're doing our skin checks, possibly even put it on the skin map so that we can observe the area. Then at the bottom, when you've inserted a cannula, you should head straight to this bit here. Why is the cannula being inserted? I don't want to know about IV access. That's what a cannula does. All right, so we want to be knowing, is that patient on medication? Are they on fluid? Or are they going for a CT scan? Okay, this is the information I want to know here. Hand hygiene and skin prep, well, that's obvious. You will always do that, so that should always be ticked. ANTT, again, obvious, but we do want to be making sure it is put there. Site, where is it on the body? What colour is the cannula? Cannula number, that's not lot number. All right, that is how many cannulas that patient has had in. For example, if the patient's gone to ED and a cannula has been inserted there, that is cannula number 1. If they then have that cannula removed and go to AMU and get a brand new cannula, that is cannula number 2. All right, number of attempts, how many times have you stabbed that patient? That's what we want to know here. And who has inserted it? If your patient comes into your ward, this information is not filled out, and they have a cannula in place, please fill it out as much as you can. So you will know the colour of the cannula, you may know the cannula number, and the site. All right, so fill in that information and then just question who's inserted it. Care plan. Cannula number, already spoken about. VIP score, this is the 0 to 5 that we should be placing here. Indication, already spoken about. And then dressing change. You can change the dressing of a cannula. Please make sure the dressing's not just left wet, bloody, because bacteria will thrive on that. So do change the dressing to a nice clean one and documenting if we are observing or having to remove the cannula. Now I'm going to show you an example of an IV. So I'm in my treatment room. And I want to get all of my equipment together, so I'm going to be touching all of the door handles, the cupboards, etc. And getting my syringe. So depending on the guidance of the medication is depending on how big syringe you've got. Then flush. Then 2% chlorhexidine wipes, 1 for your patient, 1 for your IV vial. Then I've got a mixture, okay, so it may be water for injection, normal saline, again follow the guidance of your medication. Then I've got my needle, so I have a needle without the filter, and that is a perfect combination with this one. I do not need to filter this vial but I do need a needle with a filter if I'm using a glass ampoule, so that I can filter any glass out. Right, so that's all my equipment. Then I'm going to have a look at my drug chart, making sure, right, okay, the patient is, right, okay. Any allergies? No, they've got no allergies, fantastic. Right, what is the medication I am given? I am given amoxicillin today. This is amoxicillin and my dose is 1 gram. Okay, it's been signed for and for 12 o'clock. Right, check that with that. And what I'm going to do is I'm going to wash my hands. First off, clean my tray. I'm going to remove my sharp spin. Cleaning the top bit first. Giving it a thorough clean, and then the bottom of my tray. I'm going to get my vial. I'm going to flick off the cap. Then I'm going to get my 2% chlorhexidine wipe. Opening the wipe up completely, giving it a really good scrub, using different areas of the wipe. Leave it there to dry. Going to get my syringe. So remember, protecting your key part. So my key part is down here. So I'm going to open it the other end. Peeling it open, never break through the packaging. It's not worth it. I'm going to open it up like so, get my needle, opening it up, and then placing it on. That's it. Protecting my needle, getting my water for injection, and then withdrawing the amount of medication that I need, water for injection I need. However much, yep, that's fine. Okay, just removing the air bubble a little bit. Going back to my vial, going directly in. And then get my water for injection, mixing it around, making sure it's going to get all of the medication. And then withdrawing, moving my eye of the needle right to the bottom of the vial, like so. Fabulous, that's all that medication. Removing my air bubble once more. That's it. And at this point, I'm not going to resheath. Absolutely no reason for me to resheath. So this is going straight into the sharp spin, like so. So again, remembering to protect my key part, and I'm going to put it back into the packaging because the packaging was sterile, and it's in its nice little sleeping bag, nice protected. I'm going to remove my excess rubbish. I'm going to get my flush, and now I'm going to remove my gloves and apron. So pinching it, putting it into the bin, going underneath so I'm not contaminating my hands, and then removing my apron from the back, rolling it forward, breaking it out the back, pulling it together, and then rolling it like so. Decontaminate my hands. I'm going to go to my colleague, to another member of staff who is IV trained, making sure I'm holding on to my medication and my drug chart, and I'm going to make sure that they are definitely going to check it, not just sign blindly. So if I was the other member of staff, I would make sure it's the correct patient, all right, making sure there's no allergies. Going through to the medication, so it is the correct medication, that is in date. It is the correct route, so my medication is bolus. The correct dose, did I say that? I think I did. Correct time, yeah, so it's the correct time. Water for injection, is this in date? Perfect. And 1 flush, and it's a cannula, so that's fine. So it's 5 mils before, 5 mils after. So that is fine, and that is in date as well. Lovely. So I shall sign. And then going back to myself, I will go and give this to the patient. So as I'm now going up to the patient, I will decontaminate my hands again. So my cannula here, I would always go upwards, go for the hub that's going upwards, and then that way you remember which one you have cleaned. So giving the hub a really good clean, only cleaning one hub because I'm only using one, using different areas of the wipe, like so, and then allowing to dry. I'm going to get my flush ready. Going to remove the air bubble. Go into the hub that I have cleaned. Unclip. And I'm just going to use push pause technique. So push, pause, push, pause, push, pause, push, pause, push, clip. So on that last push you want to clip so that you've got that positive patency. Placing your cannula down, like so. Putting my flush back into my packaging to protect my key part. Always remember that. Then I pick up my medication and I then place my medication in, going as quickly or as slowly as the guidance tells me to. So I'm just going to slowly go. So all my medication has been given, so that is no longer my key part, so I can throw that down, get in my flush, protecting my key part, again looking for air bubbles, pushing it in, unclip, and then clip, and that is it. That's my IV done. I'm going to tidy up so that I don't leave any mess. And I sign and I'm done. Cannulas are often used, they are easy to put in, some patients. They are for short-term use. You can't take blood from them apart from the first time you put in the cannula. That's when you can take the blood. After that, you cannot take blood from it. They can be quite fragile in the sense that you can only put through certain medications through it. They can't go home. Right, needle free. So regardless if it is your PICC line or if it is your cannula, you have needle-free bungs at the end of them. Never use a cannula without the needle-free hub on it. It's a very large hole, and this here is protecting your patient, should I say, from infections and air embolism. So always making sure that it is firmly on and you are using that correctly. That also goes for your PICC line as well. So this is your bionectar, and that is what a PICC line looks like without it. Then we move on to midlines and PICC lines. Midlines and PICC lines are both peripherally inserted. They look similar. However, a midline is not a central line. Midlines are in for about 4 weeks maximum. You can sometimes take blood from them, but then they give up the ghost and then decide not to give you any more blood. So do be careful at what patients you decide a midline goes on. Then you have PICC lines. PICC lines are fabulous. You can give a lot of medication through it, most medications through it. They are high risk of infection because they are a central line. They can be in as long as the patient requires it. We've had one maximum up to 1 year before. We have, there's 2 different types of PICC line. So the community ones have no valve, no clamp, and they are valved. So what that means is they have a little valve at the end of them, and so when you put fluid into them, the valve opens. When you take blood, the valve opens. Whereas we have open-ended, I don't know if you can see that, it's open-ended right at the end of it, and we have a clamp. Go. So PICC line dressings need to be changed 24 hours after insertion and then weekly. At a bare minimum, we must be flushing them at least once a day. In the community, they do once a week. We do it once a day here at a bare minimum. Then we move on to how to change a PICC line dressing. So first of all, I'm going to get my patient nice and comfortable, make sure I gain consent from them, and get my equipment. I'm going to clean the top of my trolley, doing a up, down, up, down, up, down, up, down technique, doing all of the different bits, doing all the different corners. Then, okay, contaminate my hands. I'm going and get all of my equipment ready. Opening up my dressing pack. Placing that down there, decontaminating my hands. This is an example of surgical ANTT. So I've shown you how to do standard ANTT with your IV, so protecting your key parts. Now everything on my sterile field is going to be sterile. So therefore I'm going to open it up, making sure I'm not touching the inside of my sterile field. That's it, opening it up. Going through my bag. Placing it on the side of my trolley. That's it. Right, this is your pick pack. These are available from Infection Control 24/7. So just come up, say hello to us, and we will give you some of these. There is a trolley outside as well. So open all of the equipment individually, never just chuck them on like so. So starting off, this is your cure prep. This is chlorhexidine impregnated, so make sure that you ask your patient for any allergies. If they are allergic to chlorhexidine, you clean the PICC line with normal saline. Then we have our grip lock. So this is a securement device. This is an external securement device, so this will hold the PICC line in place. This is another securement device. It's called a Securicath. This will hold the PICC line in place, and I'm just going to take it apart just that little bit, just so I can show you that underneath the patient's skin you have a little anchor that is holding the PICC line in place. You do not need both of these securement devices together. So if your patient has one of these, you don't need one of these. So opening that up onto my sterile field, making sure the outside of the packaging does not touch my sterile field. Then we go on to BioNectar. So I've previously stated that BioNectars help with reducing infections and also air embolisms. Every time you change the dressing, you must change the BioNectar. Underneath the BioNectar, especially if you're using certain medications, it can get not very nice. So we want to give it a really good clean and give it a good freshen up. So this is Tegaderm CHG. Again, you have chlorhexidine. If your patient is allergic to chlorhexidine, you need the alternative, which is, so you pop an IV 3000 on. The only trouble with this is your patient will not have an antimicrobial cover. Having the chlorhexidine over the insertion site will prevent them from getting infection, whereas this does not. So make sure your patient is definitely allergic to it. Up. Then I have my 2% chlorhexidine white. So opening it up, not touching it, and placing it down onto your sterile field. Last but not least, my sterile gloves. So now I'm going to put on gloves and apron. So now I'm going to take off my patient's PICC line dressing. So I'm using non-sterile gloves. I'm going to go around the outside first. I'm going to do it as delicately as possible. These dressings are very sticky because they need to be. They are on for an entire week, so they need to really stick to the patient's skin. If your patient's got really fragile skin, really take your time. Right, so I've gone all the way around the outside. Now I'm going to go up. Always go up. If you go down, you're more than likely to pull the line out. So go up, rolling it up. So go in the way in which the PICC line is going. So mine's going in a bit of a curve. So you can touch the PICC line, but just don't touch the insertion site. Alright, so at this point, I'm going to check for signs of infection. Is there anything coming out of the line? Is there any exudate, any pus? Hopefully not. I also want to see whether or not the line has moved, if it has migrated. To know if the line has moved, what you need to do is have a look at the insertion site documentation and then have a look at the line now. So as you can see, there are white dots on the line, so you need to count the white dots. Ignore the numbers, that is for insertion. So mine has 1, 2, 3, 4, 5, 6, 7 centimetres migration. So you always read between here and your insertion site. So at this point, I'm now going to remove my gloves, my non-sterile gloves, place them into my bin. I'm going to decontaminate my hands, put on my sterile gloves. What I do is use the ChloroPrep, so moving it right down to the end of the foam, checking on your glove to make sure it's definitely through, and then go back to my patient. I'm going to go straight for my insertion site, just using different areas of the sponge all the way round, giving it a really good clean. Hashtag, crosshatch, however cool you may be. There we go. If I was cleaning a Securicap, what I would do is I would pick the line up and do 360 degrees all the way around the outside, making sure that I'm getting any bits that are in between the pick line and the Securicap. Then I'm going to go to my grip lock. I'm going to remove the existing grip lock so it goes one side. So you've got a little bit of Velcro there. Pulling that off like so. Removing my grip lock. Possibly getting another member of staff to hold it in place if you're worried about the line migrating. Taking the grip lock off. Remember the little tabby bit. Pulling that to the side. Taking the pick line. Inserting it in. Taking that little bit of paper out. Moving across. Underneath you've got 2 bits of paper so you can decide where you would like to put the pick line. Don't overstretch it. You can have it curled, just make sure that the line is not kinked. So I'm just going to place it like so. 1 bit of paper and then there's another one. Then I'm going to get my CHG dressing. So you've got your chlorhexidine in the middle, so making sure that that goes directly over the insertion site, and never stretch this dressing. You stretch it and the skin will ripple and potentially it could cause blistering. So what you want to do is just gently place it on. Place it on like so. Get your lumen out the other side. Go round, taking off the bit of paper. Stick it on and place the date of when the dressing was changed. And remove that and place underneath like so. Get bits of paper out. Right, almost there. Last but not least, you need to change the bionectars. So on one side we've got a green bionector. Green and orange are exactly the same, so you can put any medication through them. This here is a TPN bionector. It has TPN on it to warn the nurses that this line is for TPN only, so it's a designated line for it. The reason for that is TPN is high risk of infection. So you do not want to be sharing that line with antibiotics and all sorts of fluids and other medication. So to change the bionector, you completely remove your bionector and you get your, picking it up and opening it all the way up, giving it a really good clean using different parts of your wipe. There we go. Then still using non-touch technique as much as possible. So either side of my bionectar is a key part. So placing on the bionectar like so. And then once you're done, place in a Kuros bung. So these Kuros bungs have chlorhexidine in them. And I will do exactly the same and replace my TPN bionectar as well. So cleaning that and then placing a brand new one on. And that's how you change it. Right, so I'll quickly go through a Securicath with you. So I've already showed you what is underneath the Securicath. So that's tucked underneath the patient's skin. So it's going to be quite difficult for the patient to pull it out. All right, so that's why it's in. Right, so the Securicath stays in as long as the PICC line stays in. Once the PICC line is finished with, we're done with all the IVs, the patient's no longer on IVs, we can then remove the line. So one side of the Securicath says hold, the other side says lift. So I'm going to hold and lift. I'm going to take that top off, placing that down. I'm going to then take out the PICC line, so getting the patient to hold their breath and then slowly pulling it out. So the PICC line's now gone. So there's two ways of removing this Securicath. One, you can fold it in half. That's probably the easiest method. So folding it at half, keeping it folded, otherwise it will just ping back open. Keep it folded, move the Securicath to the centre of the PICC line, and then what you want to do is push it down and then up. So down into the patient's skin just that little bit and then up. The other way is you would cut along the blue and do it individually, just as long as you are in this position, and then that way it'd be easier. And that is it. That is how you remove a Securicath. Go. So to take blood from a PICC line, if you want to just do normal bloods, what you do is you take off the your Kuros bung. You open a syringe, a 10ml syringe. Never use a smaller size syringe than a 10ml syringe, because that causes too much pressure on your PICC line. So you connect it on, and then what you want to do is unclip and aspirate 10 mils of blood. Then you take your 10 mils of blood and then you throw it away. You add on either a Vacutainer, or you can add on the blue one. So it's not the green, the blue. So you add this on, placing this in, twist it on, remove the dark blue, press it on and connect like so. And then you can take as much blood as you require. For blood cultures, you get your 10ml syringe, okay? You aspirate blood to the end of your line and then you take your sample. With blood cultures, you do not want to be taking any blood away. You want to get that first sample of blood. Always do blood cultures first and then any other normal bloods that you would like to take. Once you've got all the blood that you require, place this directly into a sharps bin. And then you need to make sure that you are flushing your PICC line. So with PICC lines, you always want to be flushing 20 mils after taking blood. So connecting it on and then flushing. Always use push-pause technique. Right, I'm going to talk you through an acute non-central line. So it's a central line, so it is high risk of infection, high risk of air embolisms. You've got multiple accesses here, so it is good for critical illness, but we need to be making sure that we are removing it as soon as the patient no longer needs it. So maximum time this line should be in for is 10 days, 7 to 10 days. It shouldn't be on the wards, okay, so ICU, possibly Copthorne, but preferably not. When removing the line, you've got a little suture here, so moving it just cut the suture, get the patient to hold their breath, and then take the line out. And then put pressure there and leave the dressing on for 24 hours. Skin tunneled line. So basically this tunneled line is a line that we do not have regularly in this trust. Very, very blue moon situation. So do not remove this line on the walls, all right? You can cause trauma if you take it out. The reason for this is you have a cuff all the way around. So this needs to be booked in for CPOD and removed that way, please. This line only has one access, so only compatible medication should go through this line. You could add a external lumen to it, but again, compatible medication. Always just put a dressing, like just a Tagaderm film dressing or an IV 3000 dressing for protection. And always clamp over where it says clamp here, because this part of the line is a little bit thicker and can take it. When you change the dressing needs to be changed every 7 days. Do change the bionectar as well. So implanted port. Here I have a lovely model of an implanted port. Sometimes you can look across the room and directly see the implanted port sticking out from the patient's skin. Sometimes you can't. It literally depends on the patient's, the amount of tissue the patient has. So in implanted port, the reasons that it is inserted is possibly chemo or the patient's on long-term IVs. Implanted ports can be life. They could have it all their life if they needed to, as long as it is looked after. We have had quite a few patients with it on their chest. We have had one underneath the patient's arm as well. I'm going to set up my trolley, I'm going to clean my trolley, put all of my equipment at the bottom. I'm going to wash my hands, clean my hands. So only touching the outside of my dressing pack. And go through the bin. So these packs you can get from infection control. So starting off with just a Tagaderm film, that's all we need just to protect the area over the top. So I'm going to open this up so that this is using surgical ANTT, making sure that my outside packaging does not touch my sterile field. Chloroprep, cleaning with chlorhexidine, asking your patient for any allergies. Bionectar, all lines need to have a bionectar at the bottom of it or a bung on, so that you are protected for air embolism and infection. Right, most important bit of your access is your microgripper. You have two sizes. You have your 1 inch and your 3/4. Ask your patient what size they normally have. They may know if they do not. Always start off small and then go for the bigger one. So I'm going to open this up onto my sterile field. And throw that away. I'm going to get my flush, placing this onto my sterile field, and my sterile gloves. Make sure my patient's nice and comfy. I've explained what I'm going to do. Have them lying down preferably. If they are sat up, they may just try wanting to dodge you a little bit. So it's easier if they are behind a nice firm surface so they do not move. Right, I'm going to decontaminate my hands again. First off, clean the patient's skin, so I'm going to squeeze it together, making sure the chlorhexidine goes all the way through. Press it on your glove, yeah, lovely. And then give a really big area, clean a really, really big area. For about 30 seconds. That's it, throw that away. Now what I would like to do is flush the line. So I'm going to continue to use standard ANTT and surgical ANTT, so I want to protect my key parts. So placing them on the side and just flushing them. That's it. Protecting them as much as possible, so non-touch. And placing that on like so. Right, remove that bit of plastic. And that is your needle. So this is going to go directly in the middle of my implanted pool. So this is going to go at a 90-degree angle directly in. So I've got I'm going to now palpate the implanted pool. Index finger on one side, thumb on the other, so that I know I'm going to go in the middle. So I'm going to warn the patient and go directly in. You just got to go for it. You can't hang around, go directly in. You know that you're in because the patient's not in pain or discomfort, and also the line's in, it's not hit a hard surface. So I've pierced through the skin with a needle, and I'm going to leave a catheter inside. So I'm now going to remove my needle, my safety needle. So I'm just going to push down and remove. And pull it out. You hear that click, pull it out and this is your implanted pool access. So it is a single line, so compatible medication only through. And you place your Tegaderm film over the top. So don't put it on like that, you're going to cause blistering and it'd be uncomfortable for the patient. So get it as close to the line as possible. There we go. So this, the line and the dressing needs to be changed every week. You know that you're in the right place because you get you can aspirate blood and you can flush it well as well. So to remove the line, you remove the dressing. Like so, very delicately. You want to be making sure that you have flushed the line before removing the line. So some areas they need to be flushed by heparinized saline. It depends where the line has been inserted. If it's Guildford, they are just using normal saline. Other areas might be using heparinized saline. So do ask the patient what is their normal regime. So make sure you hold on to the implanted pool and take it out at a 90-degree angle. And that is what is left in your patient.
Yep.
Yeah. Okay, flushing, super important for any of our line, PICC lines, cannulas. We must flush the line properly, making sure that we are having that positive patency. We don't want any medication left in the line or blood. This can cause a huge risk to the patient. You can have blood clots, infection risk, and potentially even septic shock. So before medication, flush the line. After medication, flush the line. And definitely after bloods as well, taking any bloods. We also want to be making sure that any of our central lines need to have Kuros bungs placed on the end of the lines as well. Thank you. Okay, just quickly at the end, sharps bins are surprisingly only for sharps. So making sure that there's no wrappers in there, there's no gloves, and that we are putting our hospital and also where abouts in the hospital we have opened it, and making sure the sharps lid is completely firmly on. So placing it down, clicking it in place, and that the lid is fully shut. Any questions, please, you're more than welcome to ask me by emailing me. My name is Rebecca Geeson, and also you can give us a call on 6651. Thank you very much.